Good morning, everybody. And the topic for today is about radio-labeled PSMA imaging and therapy, and what are the common questions and current evidence. You know that 18F PSMA and 68 gallium-based PSMA imaging is useful in patients with prostate cancer, and also several centers also use technetium-labeled tracers. And in coming to the therapies, lutetium labeled PSMA and also alpha based PSMA therapies are currently used in patients with prostate cancer. There are several retrospective and prospective studies, and most of the studies demonstrate the safety and efficacy of lutetium PSMA therapies. But for the next 20-25 minutes, I'm going to talk to you about what are the common questions you are supposed to ask, or what are the common questions your clinicians are going to ask you, or the patients are going to ask you in terms of PSMA imaging and therapies. And I'm not going to discuss about all these fancy trials, a lot of curves and patient outcomes and patient selection and exclusion criteria and all those things. But I'm going to discuss just plain, pure, common facts which everybody should know if you are into the world of PSMA imaging and therapy. So some of the questions we often ask is, what are the common sites of metastasis in prostate cancer? What's the definition of PSMA expression? And what to which organs you compare them to? And what is the survival rate in patients with prostate cancer? What do you mean by PSMA negative disease? And what proportion of patients will have PSMA negative disease, both in terms of primary as well as metastasis? And also, what is the role of bone scan in the era of PSMA imaging? What are the common sites of recurrence you need to look for when you're reporting a PSMA scan? And what is the role of dual tracer imaging, or is there any specific role for 18F FTG PET in patients with prostate cancer? And also whether the size of the lymph nodes is important, and what are the common sites of visceral metastasis. And all these questions will be answered in my next few slides. And these are the things we need to understand so that we can understand the strengths and limitations of PSMA imaging. One of the things is prostate cancer metastasis, and prostate cancer can metastasize to bones, lymph nodes, lungs, liver, and brain. And in fact, you need to also look for atypical or extranodal metastatic sites such as spleen, muscle, orbit, peritoneum, ureter, parotid glands, and kidneys. These are the atypical sites. Coming to what is the 5-year survival in patients with nodal metastasis. In fact, when the prostate cancer is confined only to the prostate gland, it's got an excellent chance of cure. But when it spreads, then the 5-year survival rate reduces. And if there is a presence of lymph node metastasis, it represents a significant adverse prognostic factor. And 5-year survival rate depends on the total number of metastatic lymph nodes. For example, it is about 75 to 80% in patients with a single metastatic lymph node, and the 5-year survival rate reduces if the number of lymph nodes increases more than 5 metastatic lymph nodes. So it falls to approximately about 20 to 30%. So in general, if it is a single metastasis, the 5-year survival is approximately about greater than 75%. And if it is more than 5 lymph nodes involvement, it is around 20 to 30%. Is PSMA expressed in normal prostatic tissue? The answer is yes. Normal prostatic tissue expresses only small amount of PSMA in the apical epithelium of the secretory ducts. Then how is PSMA ligands bind only to neoplastic prostate cells? It's an interesting concept. In fact, neoplastic transformation of prostate cells results in translocation of PSMA from the apical to the luminal surface. Therefore, it becomes more accessible to outside, and therefore it binds to the ligands. And in fact, there are two binding pockets of PSMA, such as the glutamate sensing pocket and also a non-pharmacophore binding pocket, which binds to zinc ions. And this is the basic mechanism pharmaceutical companies use in terms of the type of tracer they produce. And most of the PSMA PET ligands bind to one or both of these binding pockets. What are the common sites of PSMA expression in a normal healthy tissue? In fact, the common sites where you can see PSMA expression is the salivary glands, proximal renal tubules, lacrimal glands, epididymis, the luminal side of the ileojejunum junction, which you will see an astrocytes, and of course the central nervous system. And then comes to the question, like, what percentage of primary prostate cancer lesions have been shown to be PSMA negative? It is about 5 to 10% of primary prostate cancer lesions have been shown to be PSMA negative. And the significance of PSMA negative prostate cancer is uncertain. Why does it happen? Is if the primary tumor is not PSMA avid, then the sensitivity for detecting nodal or extranodal disease sites also reduces. So therefore, you need to look at your cross-sectional imaging more carefully in patients with negative uptake on a PSMA scan. And what proportion or what percentage of prostate cancer metastases are PSMA negative, especially the bone lesions? In about 15% of the patients, the metastasis will be negative. And again, here the question is, you need to look both at the morphological imaging as well as the functional imaging to get a definitive diagnosis. And then comes to the question is, what percentage of lymph node metastasis in prostate cancer are harbored in normal size lymph node? Because we often say size is not important, and the morphological imaging depends on the size. But in fact, 80% of the PSMA positive lymph nodes are normal sized lymph nodes. It's not enlarged lymph nodes, it's just normal sized lymph nodes. And that's how we are more sensitive compared to conventional imaging modalities. And does gallium PSMA PET-CT alter management in patients with prostate cancer? And if so, to what percentage? In fact, in general, it changes the management in approximately about 30 to 75% of patients. Therefore, PSMA imaging plays an important role in management of patients with prostate cancer. Does PSMA ligand PET imaging influence treatment in primary treatment setting? Well, the reported influence approximately changes the TNM staging in approximately about 50% of the patients, and also radiotherapy planning in approximately about 33% of the patients. But still, the information and the indications are evolving. But as of now, it changes the TNM stage in approximately about half the patients. In terms of pre-PET, PSMA predicts the positivity rate of PSMA in setting of prostate cancer. In fact, PSMA is, if the PSMA is around 0.2 nanograms per ml, your pickup rate on a PSMA scan is approximately about 40%. But the higher the PSMA, the better is the detective ratio. Therefore, if the PSMA levels are greater than 2 nanogram per milliliter, then your pickup rate is approximately about 95 plus. So therefore, PSMA study is important, but also at the time of imaging, the PSA levels also plays an important role in actively diagnosing these sites. And in fact, PSA of 1 nanogram per ml was associated with a 70% positive detection on a gallium scan. So approximately, if at all you want to do a PSMA study, at least you should have a PSMA of greater than 1. And how good is gallium PSMA in assessing invasion of seminal vesicles? Because when you look at the prostate glands, you're not only looking at the gland itself, but you also look at the seminal vesicles. So in fact, the reported sensitivity for detecting seminal vesicle invasion is approximately around 70%, and it's got a specificity of approximately about 100%. So it is useful to look at not only prostate gland as well as also seminal vesicles. Does nodal disease detection rate on a PSMA PET-CT study depends on the size of the nodes? Yes. In fact, if the lymph nodes size is less than 2 millimeter, it is very difficult to detect on a gallium-based PET-CT study. And if it is around 2 to 4.9 millimeter, your detection rate improves, and it is nearly equivalent to 60%. And if the lymph node size is greater than 5 millimeter, you pick up in about 86% of patients. Coming to FDG positive and PSMA negative lesions. It's often seen in approximately about 20 to 30% of patients. And low PSMA avidity in advanced prostate cancer is hypothesized due to dedifferentiation or neuroendocrine transformation. So whatever it is, FDG positive and PSMA negative lesions are a negative predictor for overall survival in patients with MCR PC undergoing
radioligand therapy. It remains to be evaluated if the patients with FDG positive or a PSMA negative lesion should be excluded from the trials. And in fact, the presence of an FDG positive and a PSMA negative lesions is a negative prognostic factor. In fact, if the patient's got FDG positive and a PSMA negative lesions, the median overall survival is approximately about 6 months. In comparison, the patients without FDG positive lesions and have only PSMA positive lesions, the median overall survival is approximately 16 months. Structures retained in urine, which includes bladder diverticulae, post-surgical resection cavities in the pelvis, post-instrumentation, urethral dilatation, refluxed urine into the ejaculatory ducts, and retained seminal vesicles following prostatectomy.
And frequent location of local recurrence. These are the sites you need to look carefully, especially when the scan is performed for recurrent disease. And on an overview, you may not see them very clearly on your MIP images, but if you look carefully, you need to look at the vesico-urethral anastomosis, and also less commonly in the retained seminal vesicles, posterior bladder wall, retrovesical region, and also the resection site of the vas deferens. So these are the less common sites, but these are the areas you need to look at before confirming there is no evidence of recurrent disease in these patients. That's about the imaging aspects, where you have to be careful and what percentage of the scans are negative and positive. And let's come to the area of PSMA ligand therapy. In fact, before getting into the deep diving into the therapy aspects, we need to look at the vision trial based on which it was approved VSMA by the FDA. And let's look at the study design and methods. And in fact, about 813 patients were involved in this trial. And all patients had gallium 68 labeled PSMA PET CT. And the patient selection was castrate-resistant prostate cancer, previously treated with at least one androgen receptor pathway inhibitor or one or two taxane regimes, and also had a positive PSMA study. And in fact, the patients were randomly assigned 2:1 ratio, and patients received 7.4 gigabecquerels every 6 weeks and approximately about 4 to 6 cycles, plus the protocol permitted standard of care. And half of the patients, based on the 2:1, the standard of care alone was permitted. And in fact, the protocol standard of care excluded patients on chemotherapy, immunotherapy, radium, and other investigational drugs. And in fact, the primary endpoints was image-based progression-free survival and also overall survival. And the secondary endpoints were objective response, disease control, and time to symptomatic skeletal events. And adverse events during the treatment were those occurring no more than 30 days after the last dose and before subsequent anti-cancer therapy. So coming to the results, and patients were followed up approximately about 20 plus months. And image-based progression survival was seen in approximately 8.7 months in patients treated with PSMA, and standalone standard of care were approximately about 3.4 months. And overall survival was approximately about 15.3 months in patients treated with PSMA label treatment, and the standard of care, it was around 11.3 months. And in fact, the adverse effects were seen more in patients with PSMA plus standard of treatment, approximately about 50%. And in standard care alone, 38% of the patients experienced side effects. And in terms of lutetium PSMA, all grades of toxicity, fatigue was seen in about 43% of patients, dry mouth in 39%, and nausea in approximately about 35% of patients. And again, in terms of grade 3 toxicities, 13% of the patients treated with PSMA had anemia, 8% thrombocytopenia, and 8% leukopenia. And in fact, in conclusion, radioligand therapy with lutetium PSMA prolonged imaging-based progression-free survival and also overall survival when added to the standard of care in patients treated with advanced PSMA positive metastatic castration resistant prostate cancer. Therefore, This trial changed the paradigm of prostate cancer treatment, and based on this trial, many other trials have been started, and more and more of positive findings are coming into using PSMA in various phase and various stages of prostate cancer.
What are the common questions which are often asked by the referring clinicians or by the patients is there a correlation between PSMA expression and overall survival in patients treated with lutetium PSMA therapy? What is the definition of low PSMA expression? What is the standardized treatment protocol? Do patients have more side effects if they're treated too soon? Can molecular expression of PSMA should be directly linked to PSMA efficacy? What are the trial inclusion and exclusion criteria? How soon is too soon? Is lutetium PSMA safe in patients with extensive or diffuse bone disease? Feasibility of patients with diffuse matter disease. Is lutetium PSMA useful to predict responses to PSMA therapies? That's the diagnostic images is useful or not. Does high tumor uptake of post-lutetium PSMA scans predict overall survival? And also, can we treat patients at weeks interval? So these are the common questions which come across us when you start managing patients with PSMA therapies.
And the question is, what is the minimum PSMA PET uptake of metastasis to undergo PSMA therapy? In fact, the minimum PSMA uptake of any metastasis is defined as at least 1.5 times greater than the mean liver uptake. So it has to be at least greater than liver in simple terms. Does visceral metastasis have a negative impact on overall survival of patients? The answer is yes. Patients with only lymph node metastasis with or without one or two bone lesions have a best overall survival. Patients with bone and lung metastasis grossly have similar overall survival. But again, patients with liver metastasis have worse prognosis. Patients with or without lung metastasis did not differ in overall survival. So in general, patients with liver metastasis have worse prognosis. What is the average value of what's the value of average PSMA expression of all metastasis and overall survival? In fact, the low average PSMA expression of all metastasis was associated with shorter overall survival. Means to say, if the expression of PSMA is low, the outcome is going to be bad, and there'll be a shorter survival period. Absence of low PSMA expression metastasis prior to lutetium PSMA therapy was associated with best overall survival. Means to say, if the scan shows a higher grade of PSMA expression, then this survival is going to be relatively better. What are the causes of heterogeneous cause of disease course in patients with prostate cancer? In fact, it is a combination of both genetic and non-genetic variations. And neuroendocrine differentiation in prostate cancer and outcome, in fact, it may occur in advanced stage disease, and especially after lasting androgen deprivation therapy. Prostate-specific antigen are lost during dedifferentiation, and neuroendocrine markers like neuron-specific amylase are gained. And in general, neuroendocrine differentiation is generally associated with poor overall survival. So if there is a neuroendocrine differentiation, the outcome is relatively poor. PSMA decline after PSMA therapy, how good and how bad it is? The question is, nearly 46% of the patients have greater than 50% decline after PSMA therapy. And in fact, more than 70% of the patients had some decline in PSMA after therapy. What percent of the patients show late therapy response? This is also important. We should not rush into changing treatment regimes or predict the patient's outcome. In fact, nearly 1/3 of the patients treated with PSMA therapy will show late therapy response. So therefore, at least the patient should have one or two treatments, and then you should start looking at the therapy response. But again, that is not going to give an accurate information. So you need to be patient when you're treating the patients with PSMA therapy. PSMA response in terms of lutetium PSMA versus third-line therapeutic options. In fact, there is significantly greater PSA response from PSMA therapy compared to third-line management option in a range of approximately 44% to in comparison to 22% by the third-line treatment options. So therefore, PSMA is useful in treating patients. Is pre-therapeutic gallium PSMA is a predictor of absorbed dose in terms of tumor and normal tissues. In fact, reduced salivary and kidney doses are seen in patients with high tumor burden because more of the tracer injected goes to the tumor sites. And again, parotid glands also uptake also reduces with increasing body mass and body surface area. So for only if you have more disease, therefore more tracer goes into the tumor sites, and therefore less is available for the normal tracers expressing somatostatin receptor. Therefore, the radiation dose to the normal tissues is relatively less. Dual tracer imaging, does it improve in patient selection and outcome? The answer is yes. In fact, there is a fantastic paper by Hoffman Group which shows that if the patient is PSMA negative and FDG positive, they are ineligible. PSMA positive and a combination of PSMA positive and a PSMA negative lesions is also ineligible. So all those patients who are eligible for treatment, they have to be PSMA positive, and if it's FDG positive, I mean it's concordant, then they are eligible for treatment. And if there's a discordant, they're not eligible for treatment. In fact, the best of the indications will be PSMA positive and FDG negative patients. Is bone disease adequately controlled with lutetium PSMA? The answer is no. Bone disease is less likely to be adequately treated with lutetium PSMA treatment. And also, patients with bone metastasis have a shorter overall survival and also progression-free survival, and less likely to have a PSMA reduction of more than 50% during the treatment. The possible mechanism of explanation is the tumor microenvironment. Basically, bone lesions have a higher net growth rate compared to the soft tissue lesions. Secondly, might contain pro-survival factors which is absent in other organs, and also low target expression because the lower tumor uptake in bone when compared to the lymph nodes may be the cause why bone disease will not be adequately controlled with lutetium PSMA therapy. Is dose adjustment required in patients with hepatic impairment? The answer is no. Currently, there is no evidence to support that the dose has to be reduced in patients with hepatic impairment. What are the common side effects of lutetium PSMA therapy? It starts with dry mouth in approximately 87%. It's usually grade 1. Fatigue, nausea, lymphocytopenia, anemia, thrombocytopenia are the major side effects. But again, you need to speak to the patient regularly and to pick up these things earlier during the course of the treatment. Salivary gland toxicity can be in terms of hyperfunction or dysfunction. It starts with xerostomia, which is a dry mouth, seen in approximately about 15 to 30%. And again, it is dose dependent and definitely seen in a greater extent in patients treated with alpha therapies. And in fact, the grade of salivary gland dysfunction, if it is grade 1, it is symptomatic disease with dry or thick saliva without any change in the dietary alteration. Grade 2 is patients with with grade 2 is symptomatic with significant dietary alteration, and in fact, diet is often limited to soft and moist food. Grade 3 is very problematic when the patient has got an inability to take adequate food. You have to give IV fluids or a TPN may be required. And there are various strategies to protect them, and this will be most useful if you're planning to treat alpha therapies. In fact, you can reduce the salivary gland uptake by treating compounds. You can reduction of the salivary gland damage by administering radioprotectors, and also you can do symptomatic elevation of stimulation of salivary gland secretion. Restoration of function of damaged salivary glands can be done by gene transfer, artificial salivary gland, and stem transplantation. And in terms of lutetium PSMA therapy and renal toxicity, there are a few studies looking into that. In fact, there is a high physiological expression in the proximal renal tubules, which can lead to renal toxicity in approximately seen in about 3 to 4% patients. And if prior chronic kidney disease is potentially the most significant risk factor. But what is more important is we are treating these patients as an end of line treatment or as a palliative mode of treatment. So therefore, we should not get too into stopping patients from having it treated just because of their change in renal function or there is a potential toxicity in the future. So therefore, we have to be more pragmatic and as well as more caring to the patient because this is the end line of treatment. But if you're doing as a first line of treatment, we have to look into terms of what is going to be the renal function in the next 3 or 4 years time. But if the outcome of the patient is already bad, then we should try the best on how effectively we can treat them with minimal toxicity to these organs. Contributing factors of resistant to PSMA based treatment is approximately, as I said before, 30% of the patients will have inherent resistance to PSMA based radionuclide therapy. So 30% may not respond, which could be due to heterogeneity of tumor PSMA expression, failure to deliver a significant lethal dose of radiation to the metastatic sites. Tumor microenvironment may play a significant role. A tumor biological radioresistant can also be a problematic. And because of these four hypothetic features or hypotheses, nearly 30% of the patients will have inherent resistance to PSMA-based therapies. Patients with diffuse marrow involvement or superscan, should they be excluded from PSMA therapy? The answer is no, because radionuclide PSMA therapy is efficacious and acceptable toxicity, and some patients could still benefit. So therefore, you can't exclude them. As I said before, again, this is a last resort for the patients, and therefore you have to be a little more expensive. But only thing is you need to be careful and monitor the blood test at regular intervals, and you can do some dose modification. Rather than giving a 7.4 gigabecquerels, you can change it to 5.5 or 3.5 or 3.7 or whatever it is, based on patient's condition and fitness. Does pre-treatment with radium or any other bone palliation therapies affect in terms of short and long-term outcome? The answer is prior treatment with radium and androgen receptor signaling inhibitors were found not to be associated with any long or short-term outcome in patients treated with lutetium PSMA. So in contrast, in fact, prior treatment with second-line taxane-based chemotherapy is reported to be associated with worse or overall survival in this patient. So if patients had previous second-line taxane-based, their outcome is relatively worse in comparison to patients who were previously treated with radium. So the facts, and to summarize my presentation, is PSMA is highly expressed in prostate cancer cell, as high as 100 to 1,000 times compared to normal prostate tissue. 5 to 10% of the primary prostate cancers are shown to be PSMA negative. 15% of prostate cancer patients are PSMA negative. 2% of lymph node metastases are negative for PSMA expression. 80% of the lymph nodes metastases in prostate cancer are seen in normal-sized lymph nodes. Gallium PSMA PET CT is reported to change the management plan in approximately about 30 to 75% of patients. Gallium PSMA PET CT is reported to influence clinical TSMA staging in approximately half the patients, and also radiotherapy plan in about a third of patients. Gallium-68 PSMA PET CT is useful in staging intraprostatic disease sensitivity approximately about 67% and specificity of 92%. Reported sensitivity for detection of seminal vesicle invasion is approximately about 70%, with the specificity equaling 100%. And in terms of nodal disease detection rate on gallium study depends on the size. If it is 0%, if the lymph node is less than 2 millimeter, and it increases to about 86% in terms of detection rate if the lymph node is greater than 5 millimeter. So I hope you enjoyed this lecture, and again, thanks to my mentors, and thank you all. This is the gist of the talk, and you need to read more publications, and in fact I have more than 200 to 300 questions related to basic information, and because it is just a 20-minute presentation, I might have exceeded by 5-6 minutes. If you want to have 250 questions and answers, probably I'll be coming to you next time. Have a great conference. Thank you very much.